Thank you for the invite, and we have I think so all the panelists are there. Okay, so let's jump in, and we are already delayed by around 20-35 minutes. So this is the last scientific session of the day. So our job has been made easy by the last two talks actually. So let's come to a case, and this is a 45 years old male, was operated for a right-sided buccal mucosa who underwent adjuvant radiotherapy and chemotherapy. And after 22 months, complained of a large ipsilateral neck mass of around 5 into 4 centimeters. And the FNSC was squamous cell carcinoma. So, Dr. Vijay, very simple, straightforward, does FNSC suffice in such a scenario, or you still want a biopsy to be done? Dr. Vijay, you're there? Dr. Ankit?
Yes, sir.
Yeah.
Good evening.
Yeah.
Okay, so I think DFI is 22 months. I personally, sir, in my practice, I don't usually get a biopsy done. It's the place where I'm practicing. It's very difficult to get convince the patients for biopsy and go for molecular testing. We usually go for FNACs, and if it is confirmed squamous cell, we proceed with the treatment further on.
Okay, so I think most of us would agree to that, except for if you want to run some specific NGS type of thing, which is not a standard of care in head and neck cancers at this point of time, in the squamous cell variety at least, except for the PDL1 on CPS scores, which other than that, most of us would not do that. So now switching in, and I just want to have a brief idea what the panel feels, and Dr. Kshitij can come in. What is the role of your PET CT scan in head and neck cancers? And would you recommend a PET CT scan at least in those patients who have had a relapse in every case of it, if the money is there with the patient?
Yes, sir. I would like to do it, sir.
Okay.
Yes, I would like to see.
You would like to do. Dr. Erappa,
yes,
you are there?
Yes, sir. Yes, sir. Good evening, sir.
Yeah. Would you also recommend the same thing for PET scans?
Yes, sir. Yes, sir. PET scan is required.
Okay. So I will just quickly skip this part of it. Just that, yes, on a recurrent, most of us feel comfortable if the facilities are there and patient can do it. PET scan is a good way to do it. In the upfront cases, it is not required as such, except on the rare scenarios where there's a lower neck node, probably where a CT scan thorax also could suffice. But other than that, in a recurrent setting, probably a PET scan is what people do. But other than that, you can get away with a CT scan of the thorax and the head and neck region. That's also an alternative. So now, why I put this case forward is, if this case comes to you, Dr. Vijay, you are here? Okay. Dr. Ankit, now this case comes to us as a medical oncologist. I feel all the four here are medical oncologists. Would you just think of going ahead and planning for something as a palliative intent? This patient has relapsed after 22 months, or what is your thought process?
If it is not a metastatic disease, I will definitely give a chance of cure to the patient, and tumor board is more essential for me if it is not a metastatic disease, because DFI is quite good. 22 months for me is a good DFI.
Okay. So I just wanted to make a passing comment here, because the focus of the panel is something very different. That yes, when we get a recurrent disease, we sometimes would be getting cases which are operable. And if there is a non-metastatic disease, I think a tumor board makes sense. And there could be an option of a surgery, and people have done that. And these patients do achieve a longer the chance of a cure in such cases. But this case, it was an inoperable. PET scan showed lung metastasis, and the intent of treatment definitely is palliative. That's what all of us would agree to. So now, we have a comment that second primary is not uncommon. Yes, it is not. Actually, I'm treating one case which is actually inoperable, was treated 5 years back and now I have a second primary in the tongue. That is possible, and all of us do agree to that, and that is why a tumor board and a detailed examination would be required. But this case, because it has a lung metastasis, we do agree in a squamous cell carcinoma, it is a stage 4. So now these are treatment options for this particular case. Well-to-do, good performance status, PS1, and the scenarios in front of you. Dr. Erappa, what is your take? What would you recommend for this patient?
Our setup, finance is not the problem. I will get the PDL1 status and also.
Okay. So So you would want to get a CPS, a TPS, or a PDL1?
CPS is better, sir.
At which one?
CPS.
Okay. So we have a CPS score of 10.
Then definitely I will go for single agent pembrolizumab or pembrolizumab plus chemotherapy patient is.
Okay. So we stop here. So you feel that a single agent pembrolizumab is an option, which is valid. You have the trial supporting you. Also, you also think that immune checkpoint plus chemotherapy is also an option. Okay, Dr. Shitish, what is your take? Is Shitish there? Dr. Ankit?
Yes, sir.
Yeah.
CPS score of 10, so I'm not very sure of using pembrolizumab as a single agent. Probably pembrolizumab with chemotherapy should be a better option for me, considering the CPS score of 10. In my practice, personally, I prefer using immunotherapy if the patient is affordable.
Okay. Dr. Vijay, Dr. Shitish, any one of you are there?
Yes. I'm there, sir.
Yeah,
So,
Shitish, what is your take?
Yes, sir. So I would like to give, sir, taxane plus platinum, paclitaxel with carboplatin. Immunotherapy, I would like to discuss with the patient performing. I mean, after getting the PDL1 score, the PDL1 score is 10. Yes.
CPS score is 10.
CPS score is 10. Yes, it will be discussed. Definitely. Yes, it will be discussed with the patients. All the aspects of immunotherapy needs to be discussed, but the important thing is chemotherapy should be given. Paclitaxel plus carboplatin with or without immunotherapy.
Okay, so basically there are two things that's coming out. One thing, people are looking for a targeted agent with a chemotherapy. Single immunotherapy was brought up with Dr. Arappa, which people feel that there could be an issue with this CPS score of 10, although the approval is there. So if it is a very high CPS score beyond 50, that could be a better option. But yes, with the approvals there, but because of the progression, Dr. Shitish, you feel that that would not be a very likelihood of your concern because the patient is fit. There is a higher chances of progression with single agent immune checkpoints. Is that a concern for you?
Yes, sir. My concerns of immunotherapy giving as a single agent, number one, CPS score of 10. Had it been more than 20, it would be better. Number one. Number two, the response rates are important. Chemotherapy adds on to the response rates, the duration of response. That is the second thing. And yes, definitely the concerns of hyperprogression is definitely there. If you add chemotherapy, the part.
Can I come in here? Because I saw in the last lecture the hyperprogression word came in. Would you tell a progression or a hyperprogression? Because hyperprogression has a very defined definition. And do we see that amount of hyperprogressions that, because what I mean with the trials, what has been shown is the progression of disease. I would not be terming them hyperprogressions. Hyperprogressions in head and neck cancers, I feel would be around 2 to 4%. If not, if Dr. Kumar is there, I saw him in that thing. If he's still logged in, he can come in. I think there's not a big issue in head and neck cancer as such, the hyperprogression thing. Do anyone of the panelists agree to that?
Yeah, I perfectly agree, sir. Hyperprogression is
so we want to refine it and put it that it's a progression of disease.
Progression, exactly.
Okay, right. That's fair, because I think the hyperprogression was also used in the last lecture. I think that is not the term which we would use. Okay, so anyone could go for a doublet chemotherapy and cetuximab, a TPX regimen type of thing for this patient who you want to sequence therapy. Dr. Ankit first, and Dr. Vijay, if he has logged in, Dr. Vijay.
So TPX therapy is also a very good option for me. Personally, I said personally I think pembrolizumab I'll prefer, but TPX is a very good option.
So both are valid options, but you would go for the immune checkpoint with chemotherapy combination. Any specific reason for that?
No specific reason, sir. As such, the trial that was discussed has compared extreme data with the immune checkpoint with chemo.
And
not very sure about the comparison between.
Okay, the OS data was superior. Fair enough. We take it. Dr. Vijay, you are there? No. Okay. So this is what I wanted to bring in because the nuances was the main message of this panel. If there's a large tumor near to the vessel and very important structures, that like the option of a single agent immune checkpoint would be a very dicey thing. And that's something all of us agreed. Most of the panel did agree, although technically you have an approval for a single agent immune checkpoint for a positive CPS score. And if you look at it, this is what has been discussed, and the progression of disease is around 30 to 40% if you have a single agent immune checkpoint, especially if the CPS score is also low. It's around 30-40% if the CPS score is beyond 1. If it is beyond 20, it is approximately around 30-32%. In comparison, the chemo extreme regimen looks a little better in that regards. So that is point number 1. Point number 2, if you look at, and that is negated by, as all the most of the panelists told, that if you have a chemotherapy plus the immune checkpoint, the progression of disease really comes down to around 12 to 13%, which is numerically superior, but comparative to the extreme progression of disease. So this is what most of the panel did point to. So Dr. Irappa, would you like to reconsider the thought of a well-fit, good patient of a single agent immune checkpoint because it's on the neck, sitting on the vessels? Would you think that a combination of a chemotherapy to the target therapy would be a better option for you?
Yes, sir. Combination of chemotherapy plus.
Okay, but I think that is also an option for you as per the approvals. If you look at it, a doublet chemo with cetuximab is an option. But if there's a large loco-regional disease, that would be a thing which I'll be very, very concerned, especially with the immune single agent. Cetuximab alone, I don't think most of us practice in the first line. A doublet chemo with immune checkpoint was the preferred choice, and the second choice would be a doublet chemo with cetuximab, and third would be the other agents as such. So now we move on and look into the second one. You have a bulky tumor like this, and this is a symptom, and you need a highly response for that. So, Dr. Ankit, would you be okay? But because if you look at this forest plots and look at the downward thing, although this is not conclusive, but that comes out and stands that if you have a loco-regional disease, then your chances of getting a response to cetuximab chemotherapy is slightly better than immune checkpoint. If there's a metastatic disease, the immune checkpoint combination does little better. So it is nothing to take home that you change your practice as per that, but there is something to look at it. Can we look at it that if I have a large loco-regional disease, I will go for cetuximab, TPX probably, sequence it to it, and progression of disease, I go for immune checkpoint? Or I do it the same thing because
yes, sir, exactly.
Yeah, please.
This is a very good point that you have come up with, sir, because this is very, it looks interesting, and probably where we want a good response, like a tumor, fungating tumor, we can have a look at this data and probably use cetuximab first, and then on progression we can go ahead with pembrolizumab kind of drug.
Okay, so I think the other way is also valid. It's not that anyone who does the other way is also wrong. But this is a forest plot. You have something as a hypothesis, but I don't think we take home messages from it. But this stands out because that's the only thing that really comes to the opposite of that and favors pembro. The metastatic part disease favors the pembro. Chitish, what is your take on this forest plots?
Sir, it can be an observation, but I think it needs further validation, and then only it can carry it. So still, I would vouch for immune checkpoint inhibitor with doublet chemotherapy, sir.
Yeah, point taken, and your views are well respected. And if you look at it, actually, even in the pembro and chemo also, in the 048, if you look at the forest plot, again, the same thing comes through when you look and compare with the extreme. And again, the metastatic disease actually does better. So that's a point number 1 which I put at, and definitely we have OS advantages with this combination. We have OS advantage with the other combination, but definitely the higher the CPS score, we are more comfortable with doing a single agent immune checkpoint, but a little lower positive. Most of us in this panel feel a chemotherapy arm should be there to the immune checkpoint. So that is the thing what it is. Dr. Irappa, metronomic therapy, a big data from Tata. And the ground reality, we jump back to where we are today, Monday morning. 10 out of how many patients will receive metronomic? How many will receive a paclitaxel combination? And how many will receive a target therapy, a cetuximab or immune checkpoint?
Our setup, like practicing in second tier city. And first line usually immunotherapy, like paclitaxel carboplatin, first almost 70-80% will use it in first line.
Okay. So you feel
And
that most of the patients will receive a paclitaxel.
yes,
Where would you put metronomic therapy? Because it is now, with the evidence published in the Lancet, it looks a good option, a cheap option, and it has a decent data, which looks that compared to cisplatin. Many would argue the cisplatin, which will come to it. But Shitish, do you think metronomic out of 10, would you go for a paclitaxel or would you go for a metronomic?
Hello.
Yes, Dr. Shitish, you're muted.
Yeah, Dr. Vijay is,
Yeah, Dr. Vijay.
yeah. See, for the stage 4 metastatic disease, so where disease burden is not really very high, in that condition, I can consider patient on putting metronomic therapy, and after getting progression on metronomic therapy, I will try to add platinum-based doublets. This would be my practice. Otherwise, patients who are getting progression after platinum-based doublet, I would be putting them on metronomic chemotherapy.
Okay, so you would be using a metronomic, you told in a sequential way, but my question was whom you would want to give a metronomic first and a taxane combination. Why I'm putting this point forward is, if you look at the design, all of us know that. So we know that this was a trial which was positive, but the comparator arm was single agent cisplatin. So does anyone in the panel practice single agent cisplatin as on a palliative intent for patients? Anyone? Shitish, Irappa, or Dr. Vijay? Anyone?
No.
no,
No, sir. No, sir.
Okay.
And
So
ideally,
actually,
they
yeah,
have to
please.
consider with minimum doublets, sir. Only,
Okay.
this
So
is
actually,
not-
this data from TMH comes from a valid reason that there was data to expect that there is no trial proving that the combination is superior to single agent cisplatin in terms of survival. That's why they took the comparator arm as cisplatin. So there is data, and you would not find any trial which has shown a superiority of a combination in this scenario with single agent cisplatin. I'll just skip to what it was. The point which I wanted was the responses is something which I am also concerned about. The survival thing, the PFS is okay, the OS is okay, but the responses of around 13% is something all of us feel. And if you look at the combination of Pacli, Carbo, the responses are much better. That's why probably most of us feel that Pacli Carbo is a treatment for patients who do not have the deep pockets, and we keep the metronomic for the other one. I saw Rishabh speaking about platinum refractory, and this is also a thing which I have had my point. I had my discussion with Dr. Kumar also once or twice, and the trial very well done. But if you look at the data, the patients had lot of these patients were platinum refractory. The definition in that study was around 3 months, which has been from a data. But if you look at it, the 6 months, quite a bit of patients were already relapsed within a 6 months of receiving a platinum. So probably we could also argue that platinum could not be a very good agent for those who had failed. So metronomic would be a very good choice. Dr. Irappa, do you think that I can take that for a platinum refractory, unaffordable? Metronomic is a good choice. Means a patient who has failed probably 4 months into a concurrent cisplatin and radiotherapy. This is a 22-month patient. I would prefer, if not affordable, a metronomic.
only in platinum refractory or platinum failure patients, metronomic works. And
Okay. So that could be option. Okay. So I will just come to in affordable, what will be ideal sequencing? Dr. Vijay, any idea? Because we spoke about when you are not there. Immune checkpoint first, followed by a cetuximab, or cetuximab followed by immune checkpoint. What is the thought in your mind?
See, I think,
yeah.
Yeah, I think it's better to go ahead with the immune checkpoint inhibitor first, and maybe after that, cetuximab-based doublets. Maybe.
Okay.
Yeah.
Shitish, Dr. Shitish, any idea? Any thoughts on that?
Yes, sir. First immune checkpoint inhibitors, then cetuximab, sir.
Okay. Dr. Ankit, you're back. Dr. Irappa, what is your thought?
Yes, sir. Immune checkpoint inhibitors and plus chemotherapy, CPS is good, more than 20%.
Okay.
And,
so this is one data, again, phase 2. And if you look at it, if you look at the second line treatment as per the first line, it actually tells about a different story. I think this has to be put up and proven on a larger patient subset on a phase 3 data. But if you look at it, patients who had a TPX followed by a IO did better and had a better survival and prolonged survival than the reverse. So this is the data which was published 2 years back, not in the full paper, but what to my knowledge in the presentation form. And this is the data which I could get best. This gives a hint that we probably will be getting further ideas about the sequencing as we go ahead, and these drugs can be better placed. Dr. Kumar sir, Kumar boss, you are there? No. So if it's not there, I would have had to have an opinion on this, because this is something which you do not take home as a message, but this is something that is there in the data set, and we think that this data set tells us something, but I don't think there is a take-home message, but we should keep it in mind, and we do not lose anything if you sequence it the other way. But I still believe the 048 did prove that the immune checkpoint with chemotherapy was a superior combination in that subset of patients. So last two questions. Dr. Irappa, do you do extreme or do you do a TPX in your patient pool?
TP extreme is better, sir.
TP extreme. Dr. Satish?
TP extreme, sir.
Okay, so Dr. Vijay, same answer?
Same. No, yeah.
So,
yeah, it's
so
same.
the extreme is obsolete. That's what it is coming to. Okay, so let's be honest, it's a multi-drug day protocol. Most of us are not comfortable with that, and definitely you need more additions. And also there's a data to sequencing, which I told with the caveats as already told. So this patient took paclitaxel, did not take any immune checkpoint, did not take any cetuximab. Once in 3 weeks, the progression with survival was 5 months, and the patient had progression in the lung mets. The CPS score 10, I told, was 20. Let's say it is 20. What next? Dr. Shitish first. Which is your treatment option now?
Sir, immune checkpoint inhibitor, single agent, sir.
Single agent checkpoint inhibitors is your take home at this point. A Pembro or Nivo? Let's make it more little complicated.
So more, I mean, second line we have data for both Nivo and Pembro. I'll be more comfortable using Nivos.
Okay, because you have used the drug much more. That's the
Yes,
reason.
that is the only reason. I am more confident. Yes.
Okay, Dr. Vijay, your take on that? What is your take home? What is your drug of choice?
Yeah, I will go ahead with the immune checkpoint inhibitor, and that would be nivolumab, because we have data in the second line for that. Yeah.
You have data for Pembro also.
Yeah, so it can be used, not an issue. It's more convenient and
okay. Same thing.
Yeah.
You are more acquainted with the drug. Okay,
yes.
fair enough. Dr. Irappa?
Yes, sir. I will prefer with. I will go with pembrolizumab, sir, because CPS is more than 20%.
Okay, so you will go with pembrolizumab because of higher things, but I think yeah, the data with Nivo is also fair enough. Dr. Ankit, you're back. Okay, so here I think also because the patient had a relapse within 6 months, a metronomic is a good option if the finances is not there. We heard of this trial of Checkmate 141, and we did see these graphs. We also know the keynote 040 for the Pembro data, which was again methotrexate, docetaxel, and cetuximab. The only difference between the keynote and the nivolumab is that the docetaxel was given weekly in the nivolumab trial. Here it was given once in 3 weeks. So that's 1 point difference. Does anyone have any idea about the hazards which was there with these agents? Because this is something which agent you had the maximum benefit versus the immune checkpoint. Anyone? Because there is a small line which is there in both these studies. The only thing that comes out of this, not a take-home message, again a thought process, that the docetaxel single agent arm, the hazards were the least. Means the difference of benefit was the least with docetaxel versus immune checkpoint, was the maximum with second generation cetuximab with the immune checkpoint. So this is what both the trials actually were consistent. It was around 0.8 for dosi versus immune checkpoint, and 0.5 or 0.55 for cetuximab versus the immune checkpoint. But this is again a very subset analysis. I would not take conclusion, but there's something interesting which I thought I would share with this audience. So this is what the standard of care was. Now this is my question to Irappa, who told that if there is a CPS score or TPS score, when I look at these graphs and I look here as the CPS beyond 1 and more than 1, you are exactly on the point. But look at the TPS. If I'm looking at the TPS, PDL1 less than 50 and more than 50. If I have a PDL1 less than 50, actually the graphs overlap each other. So does it make a point that whenever we use immune checkpoint, you would be comfortable with a higher PDL or CPS or a TPS score? Because this graph does tell me a story. What is your take home message, Dr. Sitish?
I think for head and neck cancers, CPS is important. Clone SP263, it has to be more than 20%, and that is it, sir.
This data was less than 1 and more than 1. Actually, we are 048 was a front line. When you look at second line, the scores just change. It is beyond 1 and more than 1.
For second line,
TPS,
sir, I don't think so.
Yeah.
For second line, sir, I don't think so. I would look at PDL1. I would look at the platinum refractoriness. So for the second line, I won't be looking at PDL1.
Does this graph tell you a story? Does this graph tell you a story that if you have a lower PDL CPS or a lower TPS less than 50, the graphs really do not separate? Because you are going to spend lakhs of rupees on the patient. Okay, Dr. Vijay, your thoughts on that?
Yeah, so whenever the this CPS TPS score or PDL expression is higher, yes, more than 50%, then surely graph will separate and we will get better overall survival and overall better response to the patient. Whenever the patient has this PDL score less than 50, then definitely it would be on the lesser side.
So this is a forest plot, again telling you the same thing. Just look at these three things. My last slide probably. Look at the TPS beyond 50 and more than less than 50. Look at the CPS more than 1, less than 1. And look at the cetuximab, docetaxel and methotrexate. Even although the numbers are small, you would not draw conclusions. But as we medical oncologists love to see these forest plots, this does tell us some story. And this is consistent for both Nivo trial and the Pembro trial. So this drug, methotrexate, docetaxel, cetuximab, the hazard score is nearly the same. So this gives me a point that if I cannot use a drug, probably immune checkpoint, and metronomic chemotherapy is a good option for me, or I would be very comfortable probably using a docetaxel single agent also, if I have not used taxanes prior to this. So this is also something which I felt I do in my practice, which I thought I will share it. So Rishabh, any thoughts on this? Because I'm just concluding.
Yes, sir, I agree that for immune checkpoint inhibitor, as we see in most of the sites, higher the CPS or TPS score as per the site, it looks that the major benefit is driven by higher CPS or TPS score. Like maybe it is more than 20 would be much better than more than 1. We don't know. That more than 1 is driven by more than 20. We don't know. So when we are spending so much of money,
really drives the benefit. Okay, as we saw in the lung cancer also.
Yeah, sir. And maybe if it is low, or if it is say 1 to 19 or 1 to 10, giving cetuximab earlier would be a better choice than giving immunotherapy agent earlier. That is what my thought process is.
So you feel that if it's less than the 20 is your cutoff for a front line, that's what you do in your practice. And if it's below 20, you do a TPS.
Grossly, sir.
Okay. So you do a TPS followed by.
Yes, sir. Grossly, I would use cetuximab with the blood.
Okay. So I would like to put some things very, very clear in my last slide. If you have a patient who is metastatic, inoperable, recurrent, who is not amenable to any local treatment, that is the point that has to be highlighted. The frontline therapies can be a single agent immune checkpoint. That thing is there, but this should be that if your scores are very high, then only you should be using it. Otherwise, the progressions can bother you a lot for single agent immune checkpoint. Cetuximab with chemotherapy, the best benefit what I could find in the data set is, first, the responses are definitely there. The progression of diseases are the least with this combination of cetuximab chemotherapy. The problem with this is the graphs probably meet very, very fast, and the immune checkpoint graphs, actually their tail is there for the patients who respond. Immune checkpoint with chemotherapy, when you add chemotherapy to immune checkpoint, the progression, that point with the progression, what happens with single agent just goes away. So people do feel comfortable to add immune checkpoint and chemotherapy as a combination because there is lesser progressions. If there's a bulkier disease, I think the combination is much, much better because the chance of progression is not there. Metronomic is a valid option. We have data now. You could use metronomic in any scenario, in platinum refractory or patients who have failed single or 2 lines of therapy. Taxanes and platinum, I think, is a very popular choice for most of us because of the responses which we get. Although the PFS is short, but the responses are very good. People do get good symptomatic relief. So this is probably how it is. In the lower CPS score, below 1, I don't think any one of us uses anything, but most of us do use chemotherapy alone and probably will use immune checkpoint in the second line, or chemo plus cetuximab in the front line and immune checkpoint in the second line. In the loco-regional large disease, I think cetuximab most of the panelists preferred, but immune checkpoint also was preferred by 3 of the panelists, and I think these are valid options. Only be careful about the progressions. PDL1, CPS, TPS, the take-home message from the panel was the higher the better, but there is a cutoff, and the CPS of 1 is probably the cutoff in second line. The CPS of beyond 20 was a comfortable limit in the first line, but beyond 1 also, you are eligible to give immune checkpoint and chemotherapy in the first line also. That's also a point which every one of us has to highlight. Any last comments from Dr. Shitish? Dr. Vijay?
So
Yeah,
just
Shitish.
1 point, sir. If the patient is, if the patient's PDL1 score is more than 20 in the first line setting, and if he is very much symptomatic, the burden of disease is very much high, and when we want a quicker response, it makes sense to add chemotherapy even if the CPS is more than 20. If the patient is chemo fit.
Agreed. So the larger disease, bulkier disease, add chemotherapy to the immune checkpoint even if there's a higher CPS score. That's the point which I brought forward, and definitely what you are seconding, and that's how we most of us practice. Dr. Vijay, any last comments?
No, sir. Yeah.
Yeah, Dr. Irappa,
Yes.
you are there? Okay.
Oh,
Dr. Ankit? Okay. Last words to the organizers. Please, and I here conclude my thank, and the last slide only. This is a data from India, and if you look at it, they have sequenced it that the patient did receive the TPX type of the weekly platinum, carboplatin and cetuximab, and they followed up with the nivolumab versus the metronomic therapy. And this is from Vivek Agrawal group from Kolkata, and they found that the patient sequenced after a weekly packed carboplatin and cetuximab, followed by a nivolumab, versus the cetuximab and chemotherapy followed by a metronomic chemotherapy. They found the survival to be superior to the sequencing of a cetuximab to nivolumab rather than the other way around. So with that, I end my panel, and thank you organizers for the opportunity, and last words from the organizers.
Thank you, TP Sahoo sir, for excellent moderation on